dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. What are we going to study today? We're going to study the posterior triangle, its applied anatomy. What about the earlier classes? Yes, I've taken a lecture on posterior triangle, its boundaries and contents. I've taken a lecture on sternocleidomastoid. This is the third in the series where we talk about the applied anatomy. Okay, so why should we study this? Because it's asked as a full question on posterior triangle. You can be asked to write a note on torticollis, Erb's point, and so on. Or you might be asked an MCQ such as this one. Should we try and solve it, students? A baby was brought to the OPD with a history of mother having undergone difficult and prolonged labor during his birth. So prolonged labor, okay? He was found to have an odd posture of the face and neck. On examination, he was diagnosed to be having Erb's palsy. Which component of brachial plexus was most likely injured? Now see here, students, they may give you 10 options. The knowledge here should come from within. What are the nerve roots that are damaged in Erb's palsy? There's no point in trying to look through these options and hope that, some amazing idea will strike you. Either you know it or you don't know it. And to know it, you have to study. Let's start. So what does this lecture comprise of? This lecture comprises of applied anatomy of posterior triangle, which, as is my habit, I group together as venous, arterial, nerves and lymph nodes related applied anatomy. So I want to start the applied anatomy related to veins first. Okay, which vein? External jugular. Basically in posterior triangle, that's what you see. So here is your external jugular vein, formed by union of posterior auricular vein and posterior division of retromandibular vein. It travels superficial to your sternocleidomastoid, pierces the investing layer of deep cervical fascia to drain into the subclavian vein. While it's traveling, it receives tributaries such as posterior external jugular, transverse cervical, suprascapular, anterior jugular. It's connected with the help of oblique jugular with the internal jugular vein. So, what is its applied importance? See, this vein pierces the investing layer of deep cervical fascia to drain. So, when it's piercing, its adventitia is fused with the deep cervical fascia. If you cut the vein, it's unable to contract to stop the bleeding. It remains open, and that results in a lot of hemorrhage. So, what should you do? Quickly cover it. If you don't cover it, it's also likely that air will enter inside, causing what is called as air embolism. So for both these reasons, you must quickly cover the cut vein. It's used as a venous manometer. Engorgement of this vein is seen in right heart failure. So what have we done? We've done the formation, we've done the cause, drainage, tributaries, and then the applied anatomy of external jugular vein. Did you note that we have covered the external jugular vein, which often comes as a short note for students? Let's now come to see if we can solve this MCQ. Following statement about external jugular vein is incorrect. Formed by union of anterior division of retromandibular with the facial vein. I won't read the rest of the options. I know A is the incorrect answer. Let's talk about applied anatomy related to arteries now. Right. We come to a very interesting phenomena, comes as a MCQ very often. It's called subclavian steal syndrome. Okay, who is stealing what? Let's understand. Okay, so here you are seeing the two subclavian arteries, the two vertebrals, the basilar artery. Okay, so you can see here that the subclavian artery seems to be narrowed down just proximal to its vertebral branch. Okay, so what happens? Proximal to the obstruction, okay, the blood that has flown, that has gone up to the basilar, crosses over to the opposite side. There is reversal of blood flow in the ipsilateral vertebral artery, and then more blood gets supplied to the subclavian and axillary artery beyond the obstruction. I know this needs to be done again. Come back. So here is your obstruction. Please note the obstruction. Now, because there's an obstruction, blood from the opposite side begins to flow through the vertebral artery, across the basilar, into the ipsilateral vertebral artery where there is a flow reversal. Please note, ipsilateral vertebral artery shows a reversal of blood flow, and finally the blood reaches the limb across the point of obstruction. MCQ again. Which of the following is true regarding subclavian steal syndrome? Reversal of blood flow in ipsilateral carotid? No. Reversal of blood flow in both vertebral arteries? No. Reversal of blood flow in contralateral vertebral artery? No. Reversal of blood flow in ipsilateral vertebral artery? Yes. Okay. Why is it called steal? It appears that you are stealing blood from the brain to supply the limb, because it's in the basilar that the blood is flowing across to the opposite side vertebral artery. Right. Continuing on the theme of subclavian, we understand that the subclavian artery passes over the first rib to continue into the limb as the axillary artery. We are aware of it. Sometimes if there is injury to the upper limb, how do you stop the bleeding? You just compress the subclavian artery against the first rib. Okay, and that's how you will stop the bleeding distally. Let's talk about nerve injuries now. Here you are seeing the posterior triangle, you are seeing the spinal accessory nerve. Okay, and these are superficial cervical lymph nodes found around it. Now just imagine that you are trying to take a biopsy of these lymph nodes. At the time when you are taking a biopsy, it is very likely that you will damage the spinal accessory nerve, which is very flush with the investing layer of deep cervical fascia, which forms the roof of posterior triangle. So this is a common injury which must be watched out for. Let's talk about irritation of the spinal accessory nerve causing what is called as spasmodic torticollis. Okay, so these lymph nodes might be suppurated. They will irritate the spinal accessory nerve lying close by. This irritated nerve causes spasm of the ipsilateral trapezius and sternocleidomastoid, and patient comes with what is called as spasmodic torticollis. Okay, now see how that's where the contraction is taking place. Now just remember, an entire section on torticollis has already been taught in my lecture on sternocleidomastoid. I want you to go see that and study about torticollis there. I won't be elaborating on that in this lecture. Alright, let's come to what is called the Erb's point. Revise here, draw with me later. Erb's point is when roots from C5, C6 unite to form the upper trunk, which gives rise to suprascapular and nerve to subclavius. And finally, the upper trunk divides into an anterior division and a posterior division of upper trunk. Got it? This single point where the 6 nerves meet is called as Erb's point. What is important about it? It's the point which is most exposed to shearing force and damage to the brachial plexus. Okay, let's draw it. It's very easy. Comes as a diagram for you. Okay, so please begin a diagram, my dear students. Okay, here, draw the C5 root, draw the C6 root, make the nerves unite from this to form the upper trunk of brachial plexus. From here, draw the suprascapular nerve, draw the nerve to subclavius, and then get the upper trunk to divide into an anterior division and a posterior division. This point where the 6 nerves meet is called as Erb's point. Got it, students? Fine. Come back to the screen. Let's talk about what is called Erb Duchenne's palsy. Look here, can you see a damage to C5, C6 roots? This kind of damage results in Erb Duchenne's paralysis. Let's discuss it. Firstly, how will they get damaged? How does C5, C6 root get damaged? Can you see this man, how badly he's fallen? Can you see how his neck is extended and the shoulders extended in the opposite direction? This kind of excessive stretching of the head in the opposite side and shoulder on the same side, or with a blow on the shoulder, or if you're putting a forceps on the head during a difficult process of parturition. Okay, all this results in traction on the C5, C6 roots, resulting in Erb Duchenne's paralysis. So that's where the damage is. Now let's talk about the anatomy of the injury. Fine, we've understood the C5, C6 is damaged. What are the nerves damaged then? The nerves damaged are suprascapular, axillary, and musculocutaneous. So if your suprascapular is damaged, which muscles are paralyzed? Supraspinatus, infraspinatus. Supraspinatus, you can't abduct your shoulder. Infraspinatus, you can't laterally rotate your shoulder. Okay? Axillary nerve, deltoid is gone, you can't abduct your shoulder. Musculocutaneous, your bicep is gone, you can't flex, you can't supinate. Okay? Coracobrachialis, loss of flexion of shoulder. Most of the brachialis, loss of elbow flexion. So the patient is not able to flex the elbow, not able to abduct the shoulder. What is happening? What is the position of the patient then? The patient comes with limb hanging limply. Why limply? Because he cannot abduct. Okay. Medially rotated shoulder. Why medially rotated? Because lateral rotator is gone. Elbow is extended and pronated. Why is it extended? Because flexors are gone. Why is it pronated? Because supinator is gone. See, when something is paralyzed, the other muscle which is still having nerve supply overacts. Okay. And finally, this is the way the patient comes, and this is called as waiter's tip position. What is it called? Waiter's tip position. Let's now come to another paralysis, Klumpke's paralysis. In Klumpke's paralysis, the C8 and T1 nerve roots are damaged. How? Same question, how? So the patient is falling from a height and he grabs onto something in an effort to protect himself. Okay, the C8 T1 roots are avulsed. This can also happen when there's a tumor of the apical region of the lung, or in case of cervical rib for that matter. Or it may happen if you're pulling on the arm of a baby during the process of parturition. All this results in damage to the roots of C8 T1. This is the way the damage is. Either C8 is gone, either T1 is gone, or both C8 T1 are gone. So what is the patient coming with? Nerves likely to be damaged are ulnar nerve and median nerve. So both carrying C8 T1 fibers. Because ulnar nerve is damaged, you will see paralysis of intrinsic muscles of the hand, all these small little muscles, and anesthesia along the medial aspect of the arm. So what does the patient come with? He's lost these muscles because of ulnar nerve damage. At the same time, the patient has lost flexors of wrist and digit. So this action is also lost because of median nerve. Question, what is happening? What is actually there? It's still preserved. It's the extensors that are preserved because the radial nerve is preserved. So, unopposed action of extensors of forearm and hand. So what the patient comes with is extended arm which is flexed like this, called as the claw hand. Claw hand. I want you to just note this, claw hand Klumpke's paralysis, because I'm taking you a little further into Scalenus anterior syndrome, which has a little bit more along with claw hand. So let's take a look first. Here you are seeing the vertebrae, first rib and clavicle. You can see the Scalenus medius, you can see the Scalenus anterior. Can you see that there is a gap between the two? This gap is called interscalene triangle. Contraction of the Scalenus anterior pulls the first rib up, reducing the space in the interscalene triangle. So whatever is passing through is going to get compressed. Question, what passes through? Brachial plexus? Yes. Subclavian artery? Yes. So both will be compressed. What will happen if the brachial plexus is compressed? You will have symptoms of Klumpke's paralysis. Lower roots are compressed, that's why. What will happen if subclavian is compressed? You will have cold limb. Okay. So now this kind of condition is called as Scalenus anterior syndrome because that's the muscle that has caused the symptoms. Right. So let's come to one more MCQ. A muscular patient who's a bodybuilder came with history of pain and weakness of his right upper limb, which increases on exercise. Remember, on exercise, Scalenus anterior becomes active. The limb feels cool to touch. Blood. When the limb is cool, there has to be a vascular compression. On investigation, he is found to be suffering from Scalenus anterior syndrome, also called Scalenus anticus syndrome. Which structures are being compressed? Is it axillary artery, C5, C6 roots? Pause. I know Scalenus anticus syndrome has got damage to C8, T1 roots and subclavian artery, which is option C. Right. One more nerve damage that you might see is called winging of scapula. What is winging? It's a damage to long thoracic nerve bell. When does that get damaged? If you are carrying heavy load on your shoulder, or if you are operating in the posterior triangle region, you might damage this nerve. This results in paralysis of serratus anterior muscle, which results in the scapula coming off, which is called as the winging of scapula. Let's now talk about applied anatomy of lymph nodes, which is the last part of today's discussion. It's very important. Okay. Supraclavicular lymph nodes might be thickened, as is seen in tuberculosis and other malignancies. You might have thickening of the left supraclavicular lymph nodes, these are called Virchow's lymph nodes. This thickening is seen in testicular cancer, in cancer of the stomach, and sometimes malignancies of other abdominal organs. So that's the Virchow's lymph node. Let's come to an important discussion, the neck dissections. First, some basics. Head and neck cancers mostly metastasize to cervical lymph nodes. That means spread to cervical lymph nodes. So, removal of these along with some associated structures is an important part of treatment. Cancer has spread to your cervical lymph nodes. You want to remove them and some associated structures. For this, you need to know level system of describing lymph nodes of the neck. They are classified into several levels. Level 1 is submandibular and submental lymph nodes. Level 2 is upper jugular. Level 3 is middle jugular. Level 4 is lower jugular group of lymph nodes. Level 5 is the lymph nodes in the posterior triangle. Level 6 is pre-tracheal, pre-laryngeal group of lymph nodes. Okay, so this is a level classification. Now, what is radical dissection of neck? When you're operating, you remove the first 5 levels of lymph nodes. All these lymph nodes are removed. Along with that, you remove sternocleidomastoid, internal jugular vein, and spinal accessory nerve. These 3. You have something called extended radical neck dissection. Here what happens? You remove the first 5 lymph nodes. Along with that, you might remove one more level, say level 7. Besides sternocleidomastoid, internal jugular vein, and spinal accessory nerve, you might also remove the carotid artery. So you are extending the surgery. Modified neck dissection is when you are reducing the surgery, more focused. So you remove the level 1 to 5 lymph nodes, but you might spare the sternocleidomastoid or internal jugular vein or spinal accessory nerve, any one. Finally, you have a selected neck dissection. Here, you are removing only the parts as per the drainage pattern of the organ affected. Okay? So, what did we discuss today? What we discussed was veins, arteries, nerves, lymph nodes, and their applied anatomy. This sheet should be used by all of you to revise. Just come to this sheet, run through, see if you remember all this, and that's your job done. Right, let's see if you can solve this MCQ now. The most common site of injury in Erb's palsy is, again use your memory, C5, C6. It's not C1, C2, it's not C2, C3, not C3, C4, it is C5, C6. Right. A young man came with history of accident a few months back, came to the OPD with difficulty in movement of his left arm and claw-like. Claw, immediately think of Klumpke's. On examination, he finds he is having decreased sensation along the medial aspect of his left arm. Okay. Where should the lesion be? Can it be left cervical plexus? No. Can it be C5, C6? No. Can it be C8, T1? Yes, likely. Damage to radial? No. So this is how knowledge helps you to solve MCQs. Finally, students, we come to the end of our discussion on posterior triangle and its applied anatomy. One advice from me is, a beautiful thing about learning is that nobody can take it away from you. This is the only thing. Knowledge is something that's in you. Nobody can take it away. They can take away a lot, but not this. Okay. So with this, I end my class. As usual, I had a great time teaching you something which is also clinically relevant, linking my subject with the clinical subjects. I love it. Okay, I hope you enjoyed it too. See you across the screen in some other lecture. All right, students. Thank you.